there was some strengths of real-world data. We're seeing quite a lot of real-world data from the American group and from the European groups. I think it gives a large number of patients and less selected in the trials. So that's one of the big advantages. The challenges, I think, are that the granularity of the data is not as good. So assessing responses is more difficult. It's not done formally, it's done retrospectively. There's obviously some bias in selecting the patients that you report. But I think it is important because the trials are, very selected groups of patients often. We try and do them as wide as possible, and the real world data gives us a bigger overview really of safety and of duration of therapy. And so we're seeing that with the targeted treatments. Consistently, MRD is being seen to be the best predictor of outcomes. So there's some, I think it was a poster at EHA which showed that in one of the German trials, I think that the MRD response is more important than the IWSL response. So if you achieve a CR, regardless of what therapy you have, and we've had this data with chemotherapy before, but now we're having with targeted treatment, MRD really predicts for outcome whether you're a PR or a CR. We're looking at the other uses of MRD in terms of comparing trials are that we have a standard 10 to the minus 4 MRD, which I think everyone now follows the CLL sort of criteria now, and it allows us to compare across trials the depth of remissions, and we're doing that. And now in some of our trials, we're using MRD to define duration of therapy, and I think that is probably where MRD is going to really change the way we treat patients and the outcome. There are trials ongoing where either MRD is being used to define duration of therapy or selection of what therapy to give, so whether to escalate therapy in people who don't achieve an MRD negative remission. So I think we're seeing more data consistently across the trials with MRD.